share my PowerPoint here for you as well before I start.
Excellent. Looks good.
And we can see it okay? Awesome.
Okay, thank you so much.
Great. Thanks, Chris, for the intro. As Chris just mentioned, my name is Irena Rebalka. I'm an assistant professor at McMaster University, and today I'm going to be speaking to you about muscle metabolism in type 1 diabetes. And before I begin, I'd really just like to thank the individuals without whom this work would not have been completed. And that's especially Dr. Thomas Hawk and Dr. Cynthia Monaco at McMaster University, as well as Dr. Christopher Perry at York University that you just heard from as our muscle mitochondrial expert. So what is type 1 diabetes? It's a complex autoimmune disease that causes destruction of the insulin-producing beta cells within the pancreas, and this results in chronic hyperglycemia. Now, while exogenous insulin remains the cornerstone treatment for type 1 diabetes, the reality is really that the disease management of glycemia using insulin still really remains a challenge. And this is because insulin therapy still results in undesired hyper and hypoglycemic fluctuations, like you see in the 8-day glucose tracing that's on the slide right now. And now these recurrent bouts of dysglycemia, as well as dyslipidemia and insulin resistance, three really prominent features of type 1 diabetes, are really largely considered to be the primary mechanisms that lead to long-term diabetes complications, including retinopathy and nephropathy, like you see on the slide there as well. So clearly, insulin therapy is not a cure for type 1 diabetes, and we really must identify adjuvant strategies that will really help to reduce the inevitable complications that these individuals face with their increasing disease duration throughout their lifespan. And this is where skeletal muscle comes into play, as I can flip all three of these red arrows to show you that the mechanisms underlying the development of these complications that I just introduced to you really all have a relationship to skeletal muscle, that being the major site for postprandial insulin-stimulated glucose disposal, also the major site of fatty acid catabolism, and also a major mediator of whole body insulin sensitivity as well. And not only that, but in type 1 diabetes, exogenous peripheral insulin injections, peripheral being the key word here, really shifts the burden of first pass insulin stimulated glucose disposal and management actually away from the liver and to the skeletal muscle. So if muscle's metabolic health is impaired in type 1 diabetes, it really seems reasonable and intuitive that this would impact the ability of this skeletal muscle to mitigate the burdens of dysglycemia and dyslipidemia and really expedite the development of these diabetic complications that I introduced to you. The crazy thing knowing all of this, though, is that it's actually not well understood if this is the case in humans, as there are really only a few studies that examine the impact of type 1 diabetes on skeletal muscle's metabolic health since the implication of standard practice aggressive insulin therapy, which is in place right now. And this is especially true with studies that are investigating type 1 diabetes at the cellular level. And relevant to kick this discussion off are really these three studies that I have on the screen here, which reported for the first time alterations in skeletal muscle's mitochondrial health with type 1 diabetes, and specifically finding that the skeletal muscle mitochondria actually have deficits in their ability to produce energy or a reduction in ATP resynthesis. And this is seen as early as adolescence by Dr. Melanie Cree-Green, which you see indicated with the 2015 there on the slide. So mitochondria are essential in regulating many cellular processes, as you can see on the left-hand side of the screen there. And really alterations in their function can have a large impact on overall muscle health. And this includes muscle mass, strength and fatigue, muscle metabolism, and also insulin sensitivity. So if we're going to target muscle, skeletal muscle in particular, to mitigate the complication development that we see in type 1 diabetes, we definitely need a better understanding of the mitochondria then in type 1 diabetes. And so we at McMaster started this investigation by recruiting physically active participants between 18 and 30 years of age with type 1 diabetes. And also something important to note about this cohort is that they had no known diabetes complications. And we also included their matched controls. So we're going to call this the young adult cohort. And we did this exact same thing with a cohort of adults aged 30 to 80 years old that in this talk we're going to call older adult cohort. So among a host of other analyses, the participants underwent a muscle biopsy and various analysis techniques, including high-resolution respirometry and electron microscopy, were conducted on these muscle biopsies. And I'd really also just like to preface any data that I'm about to show you, just to let you know that the goal of this presentation is to provide more of a high-level overview of the data and also just highlight key concepts that we found in these studies moving forward as well. So what did we find in the younger adult cohort? We'll start with them first. We actually saw lower respiration rates at physiological concentrations in ADP concentrations in those with type 1 diabetes. And this included around a 20% reduction in mitochondrial oxidative capacity. So something pretty substantial there. And this was actually similar to the findings of the studies, those 3 studies that I mentioned to you in the introduction as well. And this was kind of something exciting or interesting to find because we saw the same results, even though a different analytical technique was used in this study when compared to those 3 that I introduced already as well. Now, we also found elevated reactive oxygen species generation, as you can see on the slide, at the level of complex 3 in individuals with type 1 diabetes. And this is a concern because reactive oxygen species, as many of us might be familiar with, have the ability to damage intramuscular DNA, RNA, proteins, and even denervate motor units, and thereby basically reduce muscle strength. Now, these mitochondrial impairments actually translated to more than just a molecular finding, as the mitochondrial integrity itself was also affected. So like you can see in the micrographs that I have on the slide there, the mitochondrial cristae, which are outlined in red here, which increase the mitochondrial surface area for ATP production, were irregularly organized or even lost. You can see big gaps in the mitochondrial areas there with type 1 diabetes. And this is consistent with the reductions in mitochondrial function that I just showed you on the last slide there too. Now, very interestingly, these functional changes were not the result of a smaller mitochondrial area or smaller individual mitochondrial size, or even a lesser content of electron transport chain proteins. So essentially, the take-home message from this younger adults, from the information I just showed you, was that the younger adults with type 1 diabetes already possess abnormalities in their intrinsic or one-on-one mitochondrial function within their skeletal muscle. So basically, they have the same number and the same size of mitochondria, but every single individual mitochondria is actually functioning at a poorer level. And this again was, I'll remind you, despite these individuals being physically active and also having no known diabetes complications. So this was the younger adult cohort. What did we see in the older adult cohort with type 1 diabetes? So in contrast to the observations that we saw in the younger adults, we actually observed a significant decrease in overall mitochondrial density within the skeletal muscle of older adults with type 1 diabetes. And interestingly, if we break this down even further, we actually found that this was largely driven by smaller mitochondria in females with type 1 diabetes and a lesser number of mitochondria in males with type 1 diabetes. So a differing effect between males and females with regards to the overall presentation of this finding. And we also see another sexually dimorphic response, and this time it's in whole muscle bioenergetics. So essentially, we see lower mitochondrial respiration, which you can see here, in females with type 1 diabetes compared to controls, and no significant difference, but also pretty broad variability in males with type 1 diabetes compared to their controls. But knowing what I just told you on the last slide, there's a decrease in type 1 diabetic mitochondrial density. So this is not a wildly fair comparison. So when we normalized to mitochondrial density, we actually unexpectedly found mitochondrial respiration to be normal when compared to matched controls in females with type 1 diabetes, and actually a little bit greater in males with type 1 diabetes. And while this is kind of still a head scratcher, we really don't know the mechanism for this normalized response to ADP, but it may actually indicate the potential for a compensatory mechanism of some sort to be kicking in these individuals. And here's a little bit of an interesting clinical aside that was also revealed in this older adult cohort. So very known and confident clinical predictors, such as type 1 diabetes duration and also hemoglobin A1C, HbA1c, were actually not strong predictors of this mitochondrial function. And like you see by all of the red boxes within the male and female highlights there, this was often, in fact, negatively correlated to mitochondrial outcomes. And not only that, but these clinical predictors also displayed sexual dimorphism in their correlation with mitochondrial metrics as well. And although I didn't show you this data in the previous young adult slides, sexual dimorphism was also seen actually in many of these intrinsic mitochondrial changes detailed in the younger cohort as well. So very interesting that males and females are showing a different phenotype here. So just summarizing what I showed you in the older adults here, older adults with type 1 diabetes actually display no intrinsic deficit on a mitochondria to mitochondria basis, but they do, however, possess a decrease in mitochondrial density, which then in turn subsequently affects overall muscle mitochondrial function. So if we're going to compare and contrast younger with our older adult cohorts, once again, those under the age of 30 appear to demonstrate intrinsic mitochondrial alterations without changes in content, while changes in mitochondrial function in those over 30 years of age actually seem to be largely dependent on changes in content, where the mitochondria seem to actually be functioning at a normal or maybe even an enhanced level on an individual basis. So if we take this mitochondrial lens and we expand it a little bit, let's see if there were metabolic modifications in the skeletal muscle. Did these actually translate, or are they associated with modifications in skeletal muscle function? So in the same participants whose mitochondrial data I just showed you on the previous slides, we actually saw a progressive decrease in muscle quadriceps strength or maximal voluntary contraction with age, which might not be surprising, but what is maybe surprising is how much this slope is actually negatively affected by the presence of diabetes in both males and in females. And once again, I think it's very important for me to remind you that these participants did not actually have any overt complications of type 1 diabetes. So no neuropathy, no cardiomyopathy, and really no other associated comorbid conditions. Now, to really drive this point home as well, let me just draw an arbitrary line across the graph to exemplify frailty, which you see in yellow on the slide there. And we can see that the individuals with type 1 diabetes are reaching this point first. So knowing that frailty and a decrease in muscle mass is really strongly associated with decreased ability to conduct activities of daily living, associated with institutionalization, associated with a decreased lifespan, and really knowing that these same trends can also be seen independent of age in individuals with type 1 diabetes. Really thinking about mitigating this decline is of absolute utmost importance for this population. And we also know, if we take this kind of outside of type 1 diabetes, that in other chronic conditions, such as obesity, such as cancer, we know that muscle health and muscle strength is also a well-established determinant of quality of life and also of survival as well. So this should be something pretty important to think about. And now on top of this, you can see I've put another red line on the slide there. So think about the occurrence of maybe incidental injury or strain, immobilization, hospitalization, maybe even repetitive activity that you just need a rest and repair from. That may actually exacerbate this already exacerbated road to frailty. And again, you can see that with the red line on the slide there. Now, interestingly, we can also see this functional deficit reflected in upper body strength, and this time it's in the form of hand grip strength. Again, of course, necessary for activities of daily living, and also a strong predictor of hospital length of stay, and also of disability as well. These are actually results obtained using the data from the Canadian Longitudinal Study of Aging, and led by Lauren Turner, who I saw joined the slide today, or the presentation today. So thank you, Lauren, for this incredible and very impactful work. So just to walk you through what we see on the slide here. So when compared to their matched controls, individuals with type 1 diabetes actually display a decreased average grip strength. And this was observed both at baseline and also at a 3-year follow-up as well. And while the magnitude of the difference, or kind of the delta essentially, between the controls and the individuals with type 1 diabetes doesn't look to have changed after the 3-year follow-up, the exciting thing about the Canadian Longitudinal Study of Aging is that they actually collect this data every 3 years. So we look forward to seeing if the 6-year follow-up essentially reveals the same outcome here as well. And something else that I'll also show you within table 1, those participant demographics there, is I can also point out the sarcopenia noted in these individuals, and that being 13% higher in the individuals with type 1 diabetes relative to their matched controls, really reflecting that steeper slope that I showed you on those last slides there. And this is, I will also highlight to you, at the age of 60 years old for our controls and our individuals with type 1 diabetes. So how do we improve muscle health? Well, hopefully everybody on this call knows and appreciates that this can be done via exercise. And while studies investigating the benefits of exercise in type 1 diabetes really do provide solid data to a very new and developing field of research, few actually directly investigate the impact of exercise training on muscle metabolism, which now we know, and hopefully you know, are affected in type 1 diabetes. And to take this one step further, few studies also really directly investigate muscle repair following exercise, which not only do we know is integral following physical activity, but we also should know that it's a very energy demanding task as well. And this leads me to discuss the next study, in which we investigated the response to one single bout of eccentric exercise, both after 48 and 96 hours of repair. And this was again in young, up to 30-year-old individuals with type 1 diabetes, and also their matched controls included as well. And although we can see that the loss of force following exercise was equal, both as a whole and also in our males and females, we actually found blunted force recovery in our males and females with type 1 diabetes when compared to our matched controls. And we see that this persisted at both of the time points following muscle damage, with a decrease in recovery at around 20% on average, even 96 hours after this exercise protocol. Now, we also found an increase in the amount of muscle damage biomarker creatine kinase in circulation in individuals with type 1 diabetes. And again, this was even 4 days following exercise. And I will also highlight here for you the y-axis having a double break in it, really highlighting that the type 1 diabetic individuals did have a substantially large increase in our serum CK levels when compared to their controls. And what's clinically concerning, and why I'm highlighting this piece of data, is how the rise in other muscle cytoplasmic contents in the serum, such as myoglobin in particular, could affect kidney function of those with type 1 diabetes, particularly, of course, given the prevalence of diabetic nephropathy. Now, we can shift our attention here back to the skeletal muscle itself. And both at rest and 2 days following exercise, we see an increased presence of fibrosis, as well as an increase in skeletal muscle membrane damage. And again, also at rest, further solidifying these findings not only within the muscle itself, but also being exacerbated by damage via exercise. Now, we've learned in the last few slides that there's more damage following exercise, but what about our capacity for repair? Is this present in individuals with type 1 diabetes? And this, of course, led to the investigation or evaluation of skeletal muscle satellite cell content. For those of you not familiar with satellite cells, we can also call them the resident stem cell population within our skeletal muscle. And as you can see on the slide here, at all points, again, before and after exercise-induced muscle damage, we actually see a decrease in satellite cell content when compared to matched controls, essentially indicating a lack of the tools necessary to repair the skeletal muscle. Now, this is data that we have already actually published at rest, this time in even younger individuals, 18 to 21-year-old males. And again, this was just conducted at baseline, but this new data from 2021 really recapitulates these findings, and again, following muscle damage. And this is intriguing because it doesn't seem that these satellite cells were reactivated essentially by the need or necessity for repair to occur. And not only was satellite cell content attenuated in our individuals with type 1 diabetes, but their proliferation was delayed as well, which essentially indicates that whatever reparative satellite cells were even available were taking longer to deploy to their reparative jobs. And you can see this by this rightward shifted peak in their activation that you can see on the slide there. Kind of maybe a thought or a theory on why this is happening. Might this be due to an increase in myostatin? We know, and we've previously shown, that myostatin levels are elevated in those with type 1 diabetes. And we also know that myostatin is a known inhibitor of satellite cell proliferation. So this is definitely a future investigation that is worth continuing with, absolutely. So from this study, our main conclusion is actually that longer recovery following exercise may be necessary in individuals with type 1 diabetes, of course, due to impairments in force recovery that were observed, also evidence of exacerbated muscle damage following this damage-inducing exercise, and also, of course, due to the decreased presence of our resident muscle stem cell population. Now let's expand this exercise timeline and look at a study published by Dr. Dean Minnock at the University College of Dublin, and also led by Dr. Giuseppe DeVito at the University of Padua. And within this study, it included a 120-minute regime of weekly combinatorial resistance and aerobic training that individuals enrolled in the study underwent for a 12-week period. And so why I'm introducing this study is that it takes us from that one acute bout of exercise that I showed you on the previous slides there, and really takes this to a longer-term exercise regime for these individuals. Now, exciting. I feel like I have some good news finally, maybe for you here, as less hypoglycemic events were actually observed in individuals with type 1 diabetes in the week following this 12-week exercise intervention. And this is also an observation that's been recently supported by Dr. Mike Riddell from your home at York University. And this is following exercise investigated within the DEXY study, where they do also see better glycemic management following exercise, excitingly as well, regardless of the modality of this exercise. These individuals, back to Dr. Minnock's study here, their required insulin dosage did not change post-training, but this is certainly a very promising and exciting start. Now, again, a very positive thing, while benefits in strength and aerobic adaptations were also apparent in individuals with type 1 diabetes, these were actually not the same benefit or the same magnitude of the benefit observed in control subjects. So this team implicated increased inflammation and atrophy markers for this blunting of the strength adaptation. And back to the mitochondria playing a role here, also identified a decrease in mitochondrial adaptability at the genomic level in the participants that had type 1 diabetes. Now, let me summarize a bunch of these findings that I've laid out for you in today's discussion. And this includes altered muscle metabolism by different mechanisms in males and females with type 1 diabetes, decreased muscle strength, both observed in the upper body and also in the lower body, increased sarcopenic prevalence, and also a reduced adaptation to exercise, which I can also rephrase as a blunted benefit to the same amount of exercise undergone by those without type 1 diabetes. Now, knowing all of this information, you may actually be surprised, because I certainly was, to learn that the current exercise guidelines offered by both Diabetes Canada and also the American Diabetes Association for those with type 1 diabetes are 150 minutes of moderate to vigorous aerobic activity combined with at least 2 days of resistance training per week. Now, why does this sound familiar if you're thinking that you've heard this before? Is because these are the exact same guidelines for those provided to individuals without type 1 diabetes. Now, is this amount of exercise sufficient? And does this exercise regime provided to those with type 1 diabetes really provide the stimulus that they require to optimally benefit their skeletal muscle? At this point in time, the true answer is that we really don't know the answer to this, and especially on a cellular and a metabolic level. And this actually leads me to really excitedly announce that this work investigating these adaptations following exercise in type 1 diabetes are actually currently underway at McMaster University. So in partnership with myself and Dr. Thomas Hawk, as well as Dr. Maureen McDonald at McMaster University, we're having participants with type 1 diabetes and also their closely matched controls take part in a 12-week exercise regime following the current Diabetes Canada and American Diabetes Association guidelines, which I'll remind you again are 150 minutes of aerobic exercise and 2 days of resistance training per week. And again, really just knowing that individuals with type 1 diabetes present with skeletal muscle metabolic variations, is this regime even enough? We're really looking forward to finding out the answer to this. Participants will then undergo a 1-week detraining period, and this consists of unilateral knee immobilization. So after undergoing this exercise training and obtaining the benefits from exercise, how are these blunted by a period of no exercise? No exercise, of course, can be something that happens during a period of hospitalization, but may also happen in day-to-day life with a vacation and a week on a lounge chair on a beach or something like that. So what happens to these exercise benefits following a period of rest from the exercise? And then after this detraining period, individuals will go through a retraining period, again, following the same 150 minutes and 2 days of resistance exercise per week. Now, at all of these time points, among a host of other measures that we are taking, skeletal muscle mitochondrial health, microvascular health, and also neuromuscular health are being evaluated. And this is to inform our findings with real comprehensive mechanistic insight and hopefully lead to actual evidence-based exercise prescription to improve the functional and also the metabolic capacities of skeletal muscle in type 1 diabetes. And I really look forward to having our big research team share these results with you in the future. But for now, I'd really just like to thank you for your time, for being here and listening to us today. And really just like to take a second to thank all of our research participants, as well as the research team that has really done an outstanding job putting this body of work together. And without these people that are named on the screen, among many others, none of these studies would have definitely been possible. And I will also shamelessly add our recruitment poster for those with type 1 diabetes to the slide while I ask if anybody has any questions, and I would be more than happy to take them.
Wonderful. Thank you. Thank you very much, Irena. Excellent talk. Obviously, I have a million questions, but because we've collaborated, I will not be asking them. Everyone, if you could please raise your hand, or with one exception, Dr. Riddell, you're welcome to just undo your video. So do you have a question, Mike?
I just wanted to start off by congratulating Irena and Dr. Hawk and Chris for their major contributions in this space. They've really changed the landscape of type 1 research So I just wanted to say thanks and congratulations. I can ask a few questions later, but I just needed to say that right off the start.
Oh, thank you. That's great.
Thank you, Mike. You're certainly welcome to ask questions. Otherwise, if anyone has a question, please feel free to raise your hand. Or that is if you wish to actually ask it in person with Irena, or otherwise put it in the chat. Okay, Mike. Yeah, go right ahead.
One quick question has to do with the surprising findings repeatedly that you can't explain the decrements based on any one factor. Like if you're living with type 1 diabetes, like I am, you would think that maybe my disease duration or my average glycemic control might explain some of the findings, but they don't. They don't, and I think that's really interesting. What are your current thoughts on what are the driving factors and I guess predictors for the severity, let's say, in either mitochondrial loss or dysfunction or the reduction in MVC, which is also beautiful data. Either one. Like I don't know whether you have comments on either of those two.
No, I think it's a great question. And I think I know I said it a bunch of times and you just said it as well. It's surely surprising data, especially when you go to a clinician to have a conversation about some of this data and they're like, oh, what's their HbA1c? I bet it was less than ideal. And you say, well, they're not actually associated with one another when you take a look at this data as a whole. And I think that there are a lot of other players kind of contributing to this. One of them that I kind of briefly just mentioned there was even just the presence of myostatin. I think that in an environment of an individual with type 1 diabetes, it's intuitive or maybe well known that type 1 diabetes is associated with modifications in circulating, of course, insulin and glucose levels, but also in a lot of other factors and circulating and communicating factors. And I think that looking at essentially a whole panel of maybe some of the other modifiers of this behavior might be something that is certainly worth interrogating in the future. Because I definitely do think that there are other factors, like I said, myostatin, that might be playing a role in a lot of these factors. And it's very interesting as well. The compensatory mechanism, I think, that I alluded to is something that I would really like to see out, because it's very interesting that the function is impaired on an individual mitochondrial basis, but it also seems to be, I don't want to say survival of the fittest kind of happening with the mitochondria as an individual ages. But I think that this intrinsic mitochondrial mechanism may also be part of this conversation, or a pretty important part of this conversation.
Thanks, Irena.
And keeps both of us in business for quite a while, because there's still a lot to figure out.
Thank you, Mike. Dr. David McLean.
Yeah. Hello. Hi, Irena. Thanks. Excellent talk. Really appreciate it. Really enjoyed it. Just a quick follow-up. When you were actually giving that slide that's showing the decrease and how sarcopenia was also involved in that, that kind of made me think, are those two processes, when you have type 1 diabetes versus a control, and we all suffer from sarcopenia, but I mean, it appears to be additive. So in that case, do you think it's accelerating the same pathways associated with sarcopenia, or do you think it's acting through a different mechanism? Because if it is different, maybe there's some hope for us. If it isn't, then we're just kind of on a slippery slope. What do you think?
No, I think that that's a great point. And I think that, again, I will divert to the mitochondria maybe being the driver of this different mechanism, maybe. When you think about sarcopenia, of course, there are so many instigators or so many players that are involved in causing it. But I think I will definitely defer to the mitochondria as maybe being something that not only is implicated here, but also something that we can maybe look to target, not only hopefully with exercise, but maybe with some other adjuvant therapies to actually be able to answer that question.
Okay, thanks.
Excellent. Thank you, David. Irena, this is something that it's just a universal question with any myopathy, really, and any disease. And I don't know if we've all talked about this very much. What are your thoughts on the degree to which some of these frailty decline curves, that we're looking at and you're looking at and proposing, is due to a direct effect of the disease versus an indirect effect, potentially through physical inactivity? What do you think about the level of physical inactivity in type 1 diabetes contributing to this as opposed to the disease effect itself, or do we even know?
I think that a pretty easy answer to that is looking at the that slide that I showed you with the MVCs. Maybe unfortunately, but fortunately, a lot of the recruited participants within both the younger cohort and the adult cohort were very university and hospital a population. So basically, the individuals that were enrolled in the study were university students for the younger cohorts, but also hospital employees, MDs, researchers. And this actually lended them to be very healthy individuals. So even in our individuals north of 80 years old with type 1 diabetes, they didn't have any complications and were very healthy, were very active. And I think that this definitely speaks to the fact that it's not necessarily inactivity also exacerbating these effects, but more of something intrinsic. And I definitely agree that the inactivity, of course, plays a role in other metabolic conditions, but type 1 as well, because there is a fear of the exercise-induced modifications in glycemia, hypoglycemic events following exercise, and that does have a little bit of nervousness or apprehension built into it for individuals with type 1 diabetes. And it might even be something where one day in the future, we're already started it in the young cohort, but in the older cohort, having these individuals go through the baseline evaluations, being sedentary, and even maybe that drop in slope or that decrease in slope will even be more severe in those sedentary individuals.
Mm-hmm. Right. Absolutely. Yeah. From a recruitment perspective, are you finding people with type 1 diabetes are wanting to learn more about their disease? You know what I mean? They're very participating out of wanting to learn. That's not just giving back.
They definitely are interested in participating and learning about everything, and also being kept informed on results and findings as well. I think that there's a little bit of altruism that goes with the participation, helping themselves and helping others with type 1 diabetes, but also people with type 1 diabetes that we have come across as research participants are very interested in learning to make sure that they are also able to benefit their own personal day-to-day actions and behaviors as well.
Yeah. On that
Something that we've seen with the participants that are currently enrolled in our trial is they're actually very interested in starting their study with their matched control so that they can not only get to know them, but exercise together and things like that as well, which is definitely a new thing.
Wow.
But also I think speaks more again to that motivation and excitement to be involved.
Interesting. Okay. On that note, we actually had a request. It was a private chat actually from a participant saying they might actually want to participate in the study and asked if we might share that screen again so that they could.
Oh, absolutely.
Yeah.
We'll do that.
And while that's up, we can continue. We still have a chat.
Of course. Yeah, that sounds great. Can you guys see that again?
I see it. That looks perfect.
Awesome.
Yeah, that's good. What are your thoughts on the challenges of modeling these observations in people with type 1, modeling it in an animal model? Like, I'm vaguely familiar with the Akita. I'm not sure about others, but what do you think?
So unfortunately, a lot of the research that we did before all of this study was done in Akita animals, but not many of the results were clinically relevant or transferable to the clinical type 1 population. The primary driver for this is that the insulin administration and management of the disease phenotype is very different in humans as it is in animals. So I think that it's a good foundation for a lot of the work that has been done, but also some differences being observed as well. Differences that translated between the preclinical and the clinical models included differences in muscle mass. So again, maybe speaking to that sarcopenic presence or decrease in muscle strength, muscle mass with the disease phenotype, but a lot of the metabolic differences were very, very different between.
Okay, I didn't know that. Mike, please go right ahead.
As someone who is actively involved in writing guidelines on exercise in both forms of diabetes, I'm kind of intrigued by the hypothesis that patients might need more time off, and I think that really requires more follow-up. What is it about your next study designs that could give me a bit more confidence in that suggestion? Because right now it's not too clear, because you didn't do a training, detraining, or look at altering the dose or exposure of exercise. So I'm very interested in how that might be followed up in your own mind, because I think it's really important.
No, I think that that's a great question. And it was a little bit of decision on what the primary outcomes of interest were for the study, because I think that that's something that we can very closely monitor and control for if we were to have planned the study as being a supervised exercise training study. But then the trade-off for that and actually seeing the acute reprieve following the exercise or the rest following the exercise is, of course, that this is not necessarily testing the exercise guidelines, because those are something that they do free, within their own environment and within kind of the community or within society in their own regard. What we are doing is we are making sure that exercise is monitored and tracked, and we're giving all of the participants CGMs and also Garmin watches to be able to not only monitor their compliance, but then also have a really close idea of the exercise that they are doing and at what time they're doing that at. We have every individual before they come in for their muscle biopsy visits. So I guess I can just put that up as well. So before their baseline visit, before their 12-week, their 13-week, well, 13-week, of course, they'll already be resting, but their 17-week, we also have them doing a very strictly regimented exercise video 24 hours before they come in for their biopsy. So of course, hopefully having this be enough of a rest period, but also having this be consistent between our individuals with and without type 1 diabetes, so that if we do see any modifications, then at least we know that they've undergone the same exercise protocol before their muscle investigations.
But that doesn't get at the question that I asked, I don't think, because even if you're monitoring their activity levels, those who exercise more frequently may just be different than those who exercise occasionally from a metabolic perspective or from a muscle health perspective. So it's going to be hard to know whether you need 1 day off, 2 day off, 3 day off, or 4 days off, unless you design a study that randomizes your participants to do that. And I think that is interesting.
No, I think that that's definitely an interesting point. I think maybe, like you said, this is a good set of pilot data collection to explore that rest period a little bit further, because like I mentioned, if we're at least being confident that all of our individuals are going to be undergoing the same bout of exercise at the same amount of time prior to coming in for their biopsies, then at least that will be one time point that we can look at. And if we see differences at, for example, this 24 hours following that controlled bout of exercise, then we can use that as a foundation for, okay, now what does it look like 12 hours after and 48 hours after and things like that, even a week after, to your point of maybe having a longer break.
With a repeated stimulus that has the same.
Absolutely.
Yeah, I think that would be really interesting. So again, I don't mean to be critical. I think everything you're doing is fantastic, and I do appreciate the work. Thank you.
No, and I definitely don't take it as a criticism. I think, as you indicated when you first started chatting there's a lot still for us to figure out. And I think that even just looking at the comprehensive mechanistic evaluation of the mitochondria and the microvasculature that surrounds the muscle fibers, and looking at the neurovasculature or the neuromuscular component, will also at least give us a foundation for subsequent studies, because there certainly is no shortage of ideas that we will likely have following all of these evaluations.
Yeah, agreed. And Tom hasn't sent me any mean texts in the last 4 minutes or so, so I guess I didn't cross the barrier on that one. Thanks, Irene.
Hey, I see a comment here, a lot of complimentary comments in the chat group for you. Here's a question here. Hi, Irena, really interesting and wonderful talk. Do you have any thoughts on what may drive a decreased mitochondrial function in skeletal muscle in young adults, particularly when their glycemia is moderately controlled and their diabetes duration is relatively low?
So that's a very interesting question, and that definitely leads into highlighting the importance of looking at the microvasculature within our skeletal muscle, because there are emerging studies that are showing as well microvascular deficiencies within the capillary beds or the capillary networks within the skeletal muscle. So to take this kind of one step further, or maybe to connect the dots there for you, if there is some type of a hypoperfusion or a lower oxygenation within the skeletal muscle environment, then the theory at this point is that this is what is driving deficiencies within the mitochondria, despite the fact that there is no other damage or other concern within the skeletal muscle at that earlier age. So what we are going to do to look at the microvasculature within the skeletal muscle, and maybe actually connect these dots together ourselves within this study, is a pretty interesting and novel technique called contrast enhanced ultrasound. So essentially perfusing lipid microspheres into individuals with an ultrasound probe on top of their vastus lateralis. So essentially right where we're going to be, or right where we are doing our skeletal muscle biopsies. And you can actually watch these lipid microspheres move through the microvasculature with that ultrasound probe. And we're going to do this pre and post some 50% of your MVC muscle contractions to see if we are able to identify any deficiencies in basal resting perfusion and also exercised perfusion. So kind of to go back and summarize the actual answer there, we do think that microvascular impairments are actually preceding these mitochondrial impairments, which are preceding the complications that we see later on.
Mm-hmm. It's interesting. And is it possible that, well, I guess it comes down to exclusion criteria and so on, but to what degree might some of those vascular measures be impacted by the disease versus impacted by any medications these participants may be on, which comes to a recruitment question, but I don't know if some details are at your fingertips and maybe it has to be looked at. But what do you think? Could it be some of the therapies for that some of these people, I don't know if any of them have hypertension and things like that? Or...
So we don't actually see a difference in, from preliminary evaluations from some of these previous studies, a difference in capillary density or anything like that. And I really do think it's a function issue. We've never seen pharmaceuticals or therapeutics really be a confounding factor in our younger cohort, but maybe to speak to the recruitment part of that for our older cohort, not only will we be matching for age and BMI and sex, but we're also matching for lipid lowering and cholesterol lowering medications as well.
Okay, excellent.
So that if there are any vascular impairments or differences, then hopefully this helps to normalize that.
Yeah, right. Yes, okay. It's going to be very good. Yes, and a comment. Thank you. Looking forward to the studies. That's a great summary. A lot of interest in this work for sure. I mean, how many groups are really pursuing this sort of ambitious design and already well underway with recruitment? So it's going to be excellent. Irena, thank you so much for joining with us today. It's obviously generated a lot of discussion. The research is already having this impact on people wanting to participate, let alone asking you questions. So just on behalf of the whole Muscle Health Research Center, thank you very much for doing this.
Thanks for having me. It was fun.
Absolutely. Great summary in the chat. You're an icon. I agree with that.
Oh gosh.
Yeah.
Thank you.
Can I stay on for a bit and chat some more?
Yeah, that'd be great.
Who's hosting, Chris? You?
Yep, absolutely.
You
No
can stay
problem.
on too if you have the time. It'll just be a couple minutes.
Absolutely. And to everyone here, it's been recorded, and we'll have it on YouTube within a few days. And thank you everyone for joining. We hope to see you next Friday for our next speaker. And please watch social media for the announcement to that effect, and have a great weekend.